Welcome. Today we are going to discuss National Health Policy 2017. This is very important because this is the current policy. We are all getting guided by this policy as of today. And there are several important things in this policy. There are specific shift and change in direction, which is much visible in this policy. And we can say that whatever we have learned in the previous policies are very important so that we can understand the kind of shift which are undergoing as of now under the current policy directive. So we are going to share a screen. Yes, we have discussed the related things previously. Let me remind you about those things. In lecture 17, we discussed the first health policy that is that was initiated, that was adopted in 1983 and the Alma Ata Declaration of 1978. Then in lecture 18, we discussed the Millennium Development Goals and health related targets, which were very important. And then in lecture 19, we discussed National Health Policy 2002. And lecture 20, we covered the Sustainable Development Goals and health-related targets. These SDGs are again very important because these are meant for 15 years, which are under current, which are as of now undergoing. That is from 2015 to 2030. So this policy, National Health Policy 2017, is a reflection of some of the policy shifts at global level, which were presented under the Sustainable Development Goals. And at the same time, there are reflections related to the macro level changes, which are already going on in the country. So let us go to the policy. One thing that is very important here is this, that words are very important because several new ideas are presented through several new words. So we will try to understand the core arguments of this policy. We will not focus much on those aspects where there is a kind of continuity. We will simply refer to those continuity, but whatever new shifts are there, we'll focus on these things. So with this little introduction, let's talk about this policy and specific provisions related to this. The first important thing related to this policy is this, that the situation analysis related to the past achievements are given separately and not included in the policy document as such. So very often, if someone is going to Google the policy, he or she may not find the achievements of the previous policies because these are separated. So keep in mind, I've already mentioned the website of the situation analysis, which is the success or failure story, whatever you can say, but basically we talks about the achievements of the previous policies. This is given separately. The second important thing is related to the journey from draft policy to final policy of this National Health Policy 2017. The draft policy was launched in 2014. While the draft policy was displayed for comments on the Health Ministry website in December 2014, it took over 26 months for the final policy to see the light of the day. That means the gap between the draft policy and the final policy is of more than 2 years. And during this time period, basically several presentations were made. The Health Ministry received an unprecedented 5,000 submissions related to policy draft, which were systematically analyzed, and certain suggestions have also been included in the final draft. So this is something which is related to the technical aspect of this policy. And then there are other things, the policy shift that I just mentioned. The final policy document has certain core tensions that result from interplay between the wider new liberal logic and institutional public health logic. So as I was talking about the kind of shift which is visible in this policy, there is a specific shift from the institutional public health logic towards the neoliberal logic. The neoliberal logic is related to the kind of market-related changes or larger policy shifts, which I think all of us are already aware of. We have been referring to the new age of LPG, that is the liberalization, privatization, and globalization that started in the 1990s. And there is a reflection related to those things. So as of today, this policy has accommodated many of those changes. Now, when we talk about the tensions, basically, there are two specific tensions which have been identified by Abhay Shukla in an article published in The Wire in 2017. One is the tension between the aspiration to achieve public health goals in line with the needs of India's people in early 21st century and the constraints imposed by neoliberal fiscal conservatism and minimum government. So one specific tension means some kind of uh, mm, uh, dilemma kind of situation, some kind of argument and cross argument. The policy has one shift, but if we compare this shift, the policy has a specific direction, but if we compare this direction with the earlier policies, we find that there is some kind of moving away or departure or some kind of tension is existing. So this tension is about the minimum government and fiscal conservatism. And then the second one is related to tension between aspirants to achieve some form of health coverage for the entire population based on public health logic and the compulsions of involving a largely profit-driven private medical sector to achieve this goal. And the second important thing is related to basically the mode and mechanism of developing the universal health coverage and the kind of dependence on market kind of thing. We have been saying that health is a human right. Health is something which is a public good. Health is something which is responsibility of the state. So on the one side, there is an argument that health is a public good, health needs public investment, and on the other hand, there is a move towards private involvement and private investment. So these two specific things have been articulated, and we can see that some kind of reflection or some kind of representation of these issues are very much visible in this policy. So these are important shifts, and we need to understand these shifts in the present health policy. Now come to the National Health Policy Document 2017. The policy says that after 14 years of the last health policy, the context has changed in four major ways. So 14 years because the last health policy was adopted in the year 2003. So after 2003, 14 years, and this policy was adopted in 2017. So policy begins with this statement that the policy after 14 years, the context has changed in four major ways. So what do we mean? What do we mean by the context? The context here refers to the larger macro and micro level situations prevailing in the country and the overall policy directions which are prevailing in the country, right? So what four specific changes are there? Let us talk about them one by one. First, the health priorities are changing. Although maternal and child mortality have rapidly declined, there is growing burden on account of non-communicable disease and some infectious disease. So 2017 policy categorically identifies that although the previous policies were somehow dominated with the views related to problems of maternal and child mortality, and although there are some kind of achievements in those specific areas, but there is a growing burden on account of non-communicable disease and some infectious disease. Yes, this is a reflection of the reality. The second important change is emergence of a robust healthcare industry estimated to be growing at double digit. Now, this is a new realization. We have been referring to this point in previous policies. In 1983 policy, we said that some kind of space were given to the private healthcare providers. And then 2003 policy talked about further privatization. It talked about medical tourism. It talked about public-private partnership. And now the 2017 policy says that now there is emergence of a robust healthcare industry. Now the focus here is on the word industry because there is a realization that uh, beyond the government structure, the private structure has also developed very uh, meaningfully, and there is emergence of a robust healthcare industry. And this is estimated to grow further. So when the private care industry is growing further, then there is need of further engagement and further directives or directions related to that. Then the third change is the growing incidence of catastrophic expenditure due to healthcare cost. Policy document also realizes that the burden of healthcare is actually increasing on the part of people at large, and there is a catastrophic expenditure due to healthcare costs, which are presently estimated to be one of the major contributor to poverty. So when we say catastrophic expenditure, it means that people at large are having very uh, marginal capacity to bear the cost of that kind of health expenditure. So because of increase of the out-of-pocket healthcare expenditure, the burden of the healthcare expenditure is creating catastrophic impact, and this has become one of the important contributor to poverty. We have been talking about uh, the impacts of privatization in several other contexts, but this National Health Policy 2017 categorically says that there is a catastrophic expenditure due to healthcare cost, and this is an important contributor to causation of poverty. And the fourth one is a rising economic growth enables enhanced fiscal capacity. So because there is economic growth, so the fiscal capacity is also increasing. So these are four core shifts, or you can say the government has identified these as four important contexts, and the policy is a reflection related to responding to these contexts. New health policy is responsive to these contextual changes. Now, the primary aim of National Health Policy 2017 is to inform, clarify, strengthen, and prioritize the role of the government in shaping health system in all its dimensions. This policy categorically says that the primary aim is to inform, clarify, strengthen, and prioritize the role of the government in shaping health system in all its dimensions. It identifies the dimensions. What are those dimensions? These are very important because they talk about the aim of the policy. These dimensions are investment in health, then organization of healthcare services, then prevention of disease and promotion of good health through cross-sectoral actions, then access to technologies, developing human resources, encouraging medical pluralism, building knowledge base, developing better financial protection strategies, and strengthening regulation and health assurance. So if we focus on the aims or the primary aims identified by this policy in the context of the role of the government, we happen to find that most of these aims are related to regulation, but the component related to implementation are conspicuous by their absence. The government as such is not focusing much on its own implementation mechanism. Rather, it's talking about primarily the regulating mechanism. So it talks about investment in health, but who is going to make this investment? As we will see, the share of the government is decreasing. That means categorically it talks about the private investment. And once there is private investment, then how to organize the things. These are the priorities, right? So access to technology is there, but access to primary health care as such is not mentioned, which was a defining feature of the previous policies, right? or for that matter, it talks about developing better financial protection strategies. So it talks about the strategies, but it is not talking about how the government will come forward and share the burden of out of pocket expenditure kind of thing. So these are new things which are included as primary aim of the policy. We'll keep on seeing these kind of shifts and changes in the next few slides. Then we come to the goal, principles, and objectives. The goal, the policy envisages its goal, the attainment of the highest possible level of health and well-being for all at all ages through a preventive and promotive healthcare orientation in all developmental policies and universal access to good quality healthcare services without anyone having to face financial hardship as a consequence. You may remember while talking about the sustainable development goals, we talked about the third goal. And the third goal was attainment of the highest possible level of health and well-being for all at all ages. So the goal of this policy is categorically taken from the Sustainable Development Goal 3, right? We talked about the SDGs in the previous lecture, and the SDG 3 talks about this particular goal. Then the policy recognizes the pivotal importance of the Sustainable Development Goals, right? Sustainable Development Goals basically are a set of 17 goals which talk about different dimensions related to not only a specific area related to health, rather all possible dimensions of governance of the society. And we will see that there is a specific shift towards the goal of health in all. Earlier, we have been talking about health for all. Now, there is a shift towards health in all. That means all possible dimensions of the society will make some contribution towards achieving the goals related to health. So these things will become further visible in next few slides. Then the key policy principles are mentioned. Now, the policy principles are almost similar to the previous policies, and I think we all are familiar with these principles. It talks about professionalism, integrity, and ethics. Talks about equity, affordability, universality, then patient-centered and quality of care, accountability, inclusive partnership, pluralism, decentralization, dynamism, and adaptiveness. So we are familiar with these terms so far, and anybody interested can go for the details as provided in these slides. Then we come to the objectives. Now these objectives are highlighted because we will see that there are important shifts, and these shifts are categorically mentioned in the objectives. The objectives and aims of any policy document are very important because they define the core thrust of the policy. The thrust will come again. The first objective here is progressively achieve universal health coverage. Now, what is this universal health coverage? Universal health coverage is a very broad term, and several interpretations and mechanisms have been developed globally for this health coverage. But this policy talks about health coverage in the following words: assuring availability of free, comprehensive primary health care services for all aspects of reproductive, maternal, child, and adolescent health, and for the most prevalent communicate for the most prevalent communicable, non-communicable, and occupational diseases in the population. So, when we talk about the universal health coverage in this specific context, it is mentioned that availability of free, comprehensive primary healthcare services for all aspects of reproductive, maternal, child, and adolescent health, and for the most prevalent communicable, non-communicable, and occupational disease. The word availability is very important. It talks about availability. The policy also envisages optimum use of existing manpower and infrastructure as available in the health sector and advocates collaboration with non-government sector on pro bono basis for delivery of healthcare services linked to health card. Now, what is this pro bono basis? I've explored the meaning of the term pro bono. Pro bono is short term for the Latin phrase pro bono publico, which means for the public good. The term generally refers to services that are rendered by a professional for free or at a lower cost. That means we talk about making available the services, primary healthcare services on pro bono basis, where we can take support from the professionals or the non-government sectors on either free basis or at a lower cost basis. That means the previous policies have been focusing that the primary healthcare services will be provided by the government. And now we are saying that the government is focusing on making these things available. So a new provision is included that these services can also be taken from the non-government sector on pro bono basis. But pro bono basis is not providing something free of cost in all contexts. Rather, it may also charge some lower cost. So the word private sector is not mentioned as such, but technically a new criteria is included, that is at the minimum cost or free of cost. The scope for both the things are there. Then the next point is ensuring improved access and affordability of quality secondary and tertiary care services through a combination of public hospitals and well-measured strategic purchasing of services in healthcare deficit areas from private care providers, especially the not-for-profit providers. So this is again a very important objective, ensuring improved access and affordability. So first we are talking about availability in primary healthcare services, and then improved access and affordability of quality secondary and tertiary care services through a combination of public hospital and well-measured strategic purchasing of services in healthcare deficit areas from private care providers. So the secondary and tertiary level of services would be provided through purchasing from private care providers, but we are not talking about purchasing it from the private sector as such. Rather, we are talking about the purchasing from not-for-profit providers. The third important point here is achieving a significant reduction in out-of-pocket expenditure due to healthcare costs and achieving a reduction in proportion of household experiences catastrophic healthcare expenditure and consequent impoverishment. So although the policy is realizing that there is a catastrophic impact, but it is not stating categorically that to reduce this catastrophic impact, the public expenditure will be increased. Rather, it is saying that some kind of purchasing will take place from the private sector, but primarily from the not-for-profit sector, or the primary healthcare services will be provided on pro bono basis, which is referring to a free or a lower cost kind of thing. So a new combination is created towards taking the services from the not-for-profit organizations, non-government organizations, or you can say the private service providers. Then it talks about reinforcing trust in public healthcare system. So the government is realizing that perhaps people do not have much trust in public healthcare system. We can also say the critics have also been saying that basically the narrowing of the public healthcare system is actually creating issues, and just to address those issues, this point is included here to reinforce trust. We know that people do have trust in public healthcare system, but the problem is this, that the public healthcare systems are not that well equipped, and because of that, the lack of the services, or very often the lack of manpower in the healthcare provider under the public health sector system, some kind of deficit, trust deficit is coming into existence. The policy categorically identifies this point, how to reinforce trust in public healthcare system. Whatever services are available, there should be maximum use of those things. There should be maximum utilization of those things. This point categorically referring about the maximum use of the existing facilities under the public healthcare system. And then the next point is talking about align the growth of private healthcare sector with public health goals. So it categorically mentions the private healthcare sector. So although the previous objectives, we are not referring to the private healthcare sector as such, but here it is very specifically mentioned that some kind of alignment of the growth of private healthcare sector with the public health goals. That means although the goals are identified at a public health level, but some kind of engagement and involvement of private healthcare sector is going to be there, and some kind of alignment is sought to be achieved. Then we can talk about some of the specific quantitative goals and objectives. Basically, here the summary of everything we have discussed is visible. The indicative quantitative goal and objectives are outlined under three broad components. We need to focus on the word the indicative. Basically, when we talk about the policy and planning approaches, we have been saying that the policies or the planning are actually of several types. The indicative is actually focusing not on specific quantifiable goals, specific time-bound goals. Rather, they suggest the directions, and the agencies are not well defined. So there is a shift towards indicative planning. These goals and objectives are aligned to achieve sustainable development in health sector in keeping with the policy thrust. Now, the last important part of this policy is the policy thrust, and we'll talk about those policy thrust shortly. However, before coming to those things, the specific policy goals are also indicated here. Increase in life expectancy at birth from 67.5 to 70 by 2025. So we are looking forward for increase in life expectancy, then some kind of control over the mortality by age or other possible causes like MMR or IMR kind of thing. Then it also talks about reduction of disease prevalence and incidence. We know that in the Sustainable Development Goals, we talked about the reduction in the numbers of specific disease and their prevalence. So that goal is reflected here. We are mentioning about several diseases here, and the goal is to reduce their incidence. Then it also talks about the health system performance. And a very important point is mentioned here, increasing utilization of public health facility by 50% from current levels by 2025. That means when we have the public health facilities, perhaps these public health facilities are not getting utilized as per their capacities, and hence there is a focus on increasing the utilization of public health facilities by 50%. The health system performance is also talking about the cross-sectoral goals related to health. These cross-sectoral goals related to health are very important. I've highlighted these things. What are some of the important points here? The first point is relative reduction in prevalence of current tobacco use by 15% by 2020 and 30% by 2025. The policy was adopted in 2017, and it aimed at reduction in use of tobacco by 15% till now, that is 2020, and again 30% by 2025. We know that tobacco is a very important factor. Use of tobacco is a very important causative factor in a specific context of occurrence of cancer and several other related disease. So it talks about the other possible domain which are responsible for causation of disease. Then it also talks about reduction of 40% in prevalence of stenting of under 5 children by 2025. Then access to safe water and sanitation to all by 2020 under the SoH Bharat mission, and then reduction of occupational injury by half from current level of 334 per lakh agricultural worker by 2020, and national state level tracking of selected health behavior. So these cross-sectoral here refers to that although we are talking about these important issues under the health policy, but the issues are not confined to the health programs. Rather, these are related to the other sectors. For example, the issues are related with either the agriculture sector or the industry sector or water and sanitation kind of thing. So there is engagement of the uh, cross-sectoral issues here. Then it talks about how to strengthen the health system, and under this category, it talks about health finance. Now, there is very important point here. Rather, you can say the most important point. If you summarize the whole policy, you can summarize it by this one point. What is this one point? Increase health expenditure by government as a percentage of GDP from the existing 1.15% to 2.5% by 2025. So you may remember in the previous policy document, basically the 2002 policy, rather 2003 policy, we talked about 2002 policy, we talked about increasing the share of government expenditure up to 6% of the GDP. Although we failed to increase the share of the GDP, but this time we have categorically changed the target. So earlier we have been talking about focusing on increasing expenditure or increasing government share in the overall expenditure. But this time we are categorically redefining the vision, and we are talking about increase from 1.15% to 2.5%. Although many developed countries are spending up to 6% to 8% of their GDP to in the domain of healthcare, but now we are moving away from that kind of policy direction, and now we are very categorically saying that the share of the GDP could be increased up to a maximum limit of 2.5%, and a time specific target is given. But we know that again, although we have a very reduced target, but we are not moving in this direction. However, this shows the shift of the policy in a very specific way, and it explains why there is a move towards privatization of healthcare. It also talks about increased state sector health spending to more than 8% of their budget by 2020, decrease in proportion of household facing catastrophic health expenditure from current level by 25% by 2025. That means although it talks about increasing the health spending at the level of the states, or it talks about reducing the impact of catastrophic health expenditure, but the share of the government is not going to increase in a very significant way as we have been talking about in our earlier policy document. You can say that this is more realistic, but at the same time, this is also a huge policy shift, because earlier we had this aspiration to increase. Now this aspiration is also very much changed. Then we come to the 4 points, the policy thrust. Ensuring adequate investment, the policy proposes a potentially achievable target of raising public health expenditure to 2.5% of the GDP in a time-bound manner. So as we stated in the earlier slide, here very specifically it is mentioned that 2.5% of the GDP. Then preventive and promotive health. The policy articulates to institutionalize intersectoral coordination at national and subnational level to optimize health outcome through constitution of bodies that have representation from relevant non-health ministries. So on the one side, we are talking about reducing, or you can say the reducing the long-term goal of increasing the health expenditure up to 8% or 6%. And this time we are becoming more realistic by saying that we want to increase it only up to the level of 2.5% of the GDP. And on the other side, we are talking about a very important thrust, which is highlighted in red again. This is in line with the emergent international health in all approach as complement to health for all. So you may remember 1978 Alma Ata Declaration talked about health for all. Then in 1983 policy, we talked about the goals of health for all. But now there is a kind of shift in this target. Although we are talking about health for all, but the approach would be health in all. So what do we mean by health in all? Basically, the implication of that phrase health in all means that there are different and multiple sectors, and each of those sectors have implications on health issues. For example, there are goals related to poverty reduction. There are goals related to education. There are goals related to increasing gender equality. There are goals related to environment or sustainability. And the issues related to health are getting reflected in all those sectors or the goal priorities. So we will not keep on focusing only on the target of health for all. Rather, we'll try to engage the perspective of health in all. This is a very important shift. This is in alignment with the sustainable development goals, but the implications depend upon how these goals are supposed to be achieved or implemented. And when we look at it from the perspective of implementation, we see that the government is actually intending to reduce the expenditure from the government and intend to achieve these goals through the involvement of the private players, right? This is what is generally identified as privatization of healthcare, privatization of health. So these policy thrusts actually help us to understand the already undergoing move towards privatization of health and healthcare in India. The policy identifies coordinated action on 7 priority areas for improving the environment of health. So we are talking about the environment of health, and there are 7 priority areas identified: the Swachh Bharat Abhiyan, balanced healthy diet and regular exercises, addressing tobacco, alcohol, and substance abuse, then Yatri Suraksha, preventing death due to rail and road traffic accidents, then Nirbhay Nari, action against gender violence, then reduced stress and improved safety in the workplace, reducing indoor and outdoor air pollution. So we are talking about several possible areas which have some kind of implication for the health related issues. This is something that we are talking about health in all kind of policy approach. These areas have been identified, and the overall environment for health is sought to be improved. But the issue is this, that how to improve those things, and the answer is through involvement of the either the non-government organizations or the private providers. Some of the other important thrust areas are here. Organization of public healthcare delivery. The policy proposes 7 key policy shifts in organizing healthcare services. So finally, everything is summarized here. When we talk about organization of public healthcare delivery, this is something which is related to the implementation aspect, and 7 key policy shifts are identified here. What are those policy shifts? As we have been talking about, first, in primary care, from selective care to assured comprehensive care with linkages to referral hospital, right? We are talking about primary health care. We are talking about some kind of linkages to referral hospital. Then in secondary and tertiary care, from an input oriented to an output based strategic purchasing. So categorically, we are talking about engaging the strategic purchasing as identified earlier. Then in public hospital, from user fees and cost recovery to assured free drug diagnosis and emergency service to all. We are talking about emergency services to all, but how to achieve this is something that is the core area of tension or core area of policy shift. Then in infrastructure and human resource development, from normative approach to targeted approach to reach underserviced areas. So although we identify the concept of underserviced area means the areas in which services are not provided or services are not made available. Then in urban health, from token interventions to on-scale assured intervention to organize primary healthcare delivery and referral support for urban poor. These are some of the points which have been criticized uh, for the urban health sector. We are stating in the policy from token intervention to on-scale assured intervention. So if we are saying that the existing provisions are token interventions, then what this policy is providing in terms of making those token things concrete things. So instead of focusing on providing government services to those areas, uh, the problems are identified, but the solutions are provided in a different way because collaboration with other sectors to address wider determinants of urban health is advocated. So collaboration is appearing again here. Then in national health programming, integration with health system for program effectiveness and in turn contributing to a strengthening of health system for efficiency. Then in Ayush services from stand-alone to three-dimensional mainstreaming. We talked about increasing engagement of the Ayush services. You might have read at length about the Ayush. Uh, if you have not attended those lectures previously, Ayush is a short term for uh, department at the Ministry of uh, the second ministry related to health in India, and Ayush refers to Ayurveda, Yoga, Unani, Siddha, and homeopathic system of treatment. So earlier in India, we had a Ministry of Indigenous Medicine and Homeopathy. Now that was renamed as Ministry of Ayush that exists independently. So the main ministry related to health is Ministry of Health and Welfare, Ministry of Health and Family Welfare, and then this is the second ministry which takes care of the indigenous system of indigenous medicines in India. The policy envisages the strategic purchase of secondary and tertiary care services as a short-term measure. The strategic purchasing refers to the governments acting as a single payer. The order of preference for a strategic purchase would be public sector hospital followed by not-for-profit private sector and then commercial private sector in underserved areas based on availability of services of acceptable and defined quality. So here we are talking about the remaining undefined things. Straightforward, we are talking about that the strategic purchases will take place by the government. The government will purchase the services and the services will be purchased first from the not-for-profit private sector and then from the commercial private sector. We know that not-for-profit private sectors have limited presence in India. So primarily we have the presence of the commercial private sector, and the policy categorically says that the services will be purchased from them. Then we talk about the ongoing programs, and we can have a reference of these ongoing programs in previous lectures also. So the first ongoing program is related to that reproductive and maternal and child health care. So this RMNCH plus A services then child and adolescent health services, then interventions to address malnutrition and macronutrient deficiency, and several other programs related to immunization, then prevention of communicable, control of communicable disease, then control of tuberculosis, control of HIV/AIDS, leprosy elimination. That means although the existing disease control programs are there, some kind of alignment will be taken from those programs. But for the next decade or till we have the next policy, will follow these new directions or directives. And these directives are actually already in operation. So these are the important core arguments of this policy. And these policies are, the impact of these policies are already visible. Some other points have also been mentioned here. Then we come to the last point as mentioned in the policy document. The last point of the policy document says that it talks about the implementation framework and way forward. And it says a policy is only as good as its implementation. The National Health Policy envisages that an implementation framework be put in place to deliver on these policy commitments. Such an implementation framework would provide a roadmap with clear, deliverable, and milestones to achieve the goals of the policy. So it does talk about implementation, but primarily it has already discussed how to organize the health services, and the shift is very much visible in all other provisions related to this policy. So now we come to the next part, which ideally should have been discussed during the beginning of this lecture, which is related to situation analysis. That means what kind of health situation is prevailing in India. But we have discussed the situation in our earlier lecture when we were talking about the Sustainable Development Goals, or when we were talking about the achievements of National Health Policy 2002. So whatever the achievements of 2002 policy are there, some of those points are repeated here. Yes, you can go through these things just in a quick reference. So this is the end of our slides, and we would like to conclude by saying this, that although the National Health Policy 2017 is addressing to the existing problems, but the critics have been saying that this policy is moving in the direction of privatization of healthcare, and the focus or the practice of focusing on providing public health care services is somehow getting narrowed, and the space for the engagement with the private healthcare services are increasing. So this is what this policy document is, and thank you very much for attending this lecture. I hope I was in a position to make you understand some of the specific thrust areas and policy shifts related to this policy. These things are actually emerging and engaging and involving. So in the coming years, we may find some kind of a new add-on on this policy. A policy document is certainly providing guidelines, but it is not necessarily a final point or a closing point. Yes, it helps us to understand the future, but it depends upon the national government to introduce new programs. As we know, during this COVID-19 phase, several new policy shifts have been introduced, several new provisions have been included. The health care structure has been revamped in many of the states, and the healthcare provisions have been made more inclusive. So thank you very much for watching this.